everyone, and thank you for being here today. Welcome back to this episode of Season 2 of MG Matters, a part of the Rare Disease Connect in Neurology. I'm Pushpa Narayanaswami, and I have with me today a dear friend and a brilliant complement guy, Dr. Srikanth Muppidi, who's Associate Professor of Neurology at Stanford University. And he is going to talk to us about the role of complement in myasthenia gravis. So, Dr. Muppidi, please introduce yourself to the audience.
Sure. I'm Sri Muppidi. I'm one of the neurologists specialized in myasthenia. I work at Stanford University.
Thank you so much for being here with me, Sri.
Sure.
When we learned about myasthenia gravis, one of the first things we learned was how myasthenia gravis is a prototype of an autoimmune disorder because of antibodies. And it, once Patrick and Lindstrom sort of described the pathogenesis, it meets all of those criteria for an autoimmune disorder. Do you want to talk to us a little bit about autoantibodies in myasthenia gravis and what they do?
Sure. So myasthenia gravis is one of the well-known autoimmune antibody-mediated disease, and it's caused by pathological IgG antibodies. And the antibodies are targeted against different proteins. So the most common one is the AChR, acetylcholine receptor protein. There are other ones like MuSK protein or LRP4 proteins. And these antibodies are truly pathogenic, and this has been proven by active studies and passive transfer studies. We know more about them beyond just the fact that the antibodies are pathogenic. The antibodies cause disease through direct antibody-mediated process and complement-mediated process.
And so can you explain a little bit more about the antibody-mediated processes and the complement-mediated process? Are you talking about, say, something like protein-protein interactions and sort of ligand-gated interactions where you have abnormal activation of complement?
So one of the common ways we all learn is that the antibody binds to the receptor and causes damage. And so there is either a binding or a blocking of the protein on the postsynaptic membrane.
By protein, you mean the acetylcholine
receptor antibodies. Or if it would be, if somebody has MuSK antibodies, it will be the MuSK protein that's being bound. Beyond that, for the acetylcholine receptor antibodies, there is activation of complement. This is very specific for the acetylcholine receptor antibodies. And while this was known for a while from a basic science model, from electron microscopy pictures, there hasn't been any significant interventions or therapeutics available for a long period of time.
Right. And so, and you're saying that complement is not much of a player when it comes to the pathogenesis of MuSK antibody-mediated myasthenia gravis. So let's talk a little bit about complement here. I mean, this is taking me back to my medical school days of immunology again, Sure. I vaguely remember there were these 9 proteins, something, and then they do something and, I have all of these convoluted reactions, which I had to sit up late night with cups and cups of coffee to, memorize. Sure. And then something would happen at the end and there'd be holes in membranes. Yes. That's about all I remember. So can you actually be a little bit more scientific about holes in membranes and weird reactions?
The complement is a series of proteins that are activated when there is an autoimmunity process, like an immune-mediated process or IgG-mediated antibody process. At least in myasthenia gravis, the IgG antibodies activate complement complex pathways, and there are multiple pathways, but the key pathway that's activated leads to something called membrane attack complex, which is a series of complement proteins that are deposited in the postsynaptic membrane. The complement is also important to prevent infections. It's important to remember that it's not just there as a part of an autoimmune disease, it's also there to prevent certain infections.
Right, and that makes a lot of sense because it's not just made to bug us and create diseases in our system. It actually has a protective role. So then one wonders then, if you're going to do something like inhibiting complement, you have to be careful not to remove that protective role, isn't it?
Yes. So if you were to block complement pathways or at least prevent the membrane attack complex from forming, there is always this concern that the patients might be at a higher risk of certain types of infections. Complement is critical for encapsulated bacterial infections, and so that would be one important thing, and there are strategies in terms of vaccinations, maybe prophylaxis, to prevent that from happening, especially if you're using complement therapies or complement inhibitor therapies in practice.
What do we mean when we say complement inhibitor therapies?
So these are therapies that block the complement cascade at different steps. The most commonly one that are available, commonly used, are C5 complement inhibitor therapies. So these are drugs or medications that bind to C5 and prevent the C5 protein from breaking down into C5a and C5b. And C5b binds to 6, 7, 8, and 9. These were the numbers that we all learned in med school to form the membrane attack complex. So if you could think of that chain, if you block it at C5, things below that chain won't happen. And so the membrane attack complex doesn't form. And there won't be as much damage to the postsynaptic membrane, which, as you know, is a critical part of the neuromuscular junction transmissions.
So we are going down the pathway and everything's fine until we get to C5, and then these drugs don't let C5 break down into C5a and C5b.
Yes.
What is the status of complement inhibition therapy right now in myasthenia gravis?
So it's an exciting time in myasthenia gravis because there are multiple complement inhibitor therapies that are potentially available for our patients.
So tell us how we could use these optimally. Where do you think they fit in treatment?
From the earlier data, we know that these complement inhibitor therapies reduce the symptom burden dramatically in patients as measured by MG-ADL, for example. Some of the data also suggests that patients can reduce their steroid dosing, their other immunosuppressive agents for sure. Earlier, after drug approval, at least with the first drug, patients were selected based on the refractory status. Patients who are on the severe side of symptom burden.
And by refractory, you mean didn't respond to other treatments?
Refractory means patients who did not respond to other traditional therapies. But more and more data suggests that perhaps earlier treatment, reducing the steroid need, might be more helpful, and you could have earlier disease control. This always has to be weighed against the risks of any new therapies. One specific thing that all physicians should know about complement therapy is that patients will require vaccinations before starting complement therapy. And there is a standardized process for all these drugs as to how to go about the vaccinations, and multiple national authorities have recommendations. And this is an important step as if you're thinking about complement inhibitor therapy in practice.
You said earlier that the inhibition of complement predisposes to infections by encapsulated bacteria. Are we talking about vaccinations towards specific encapsulated bacteria here?
Yes, so the specific vaccinations are against Neisseria meningitis and Neisseria bacteria. This particular bacteria can cause a severe form of meningitis, and so there are multiple vaccinations available. And there is a tetravalent vaccine and a meningococcal B vaccine, and these are a requirement part of the prescription of these complement inhibitor therapies.
Are there other encapsulated organisms to which these patients are susceptible? And are there any other vaccines that we should be thinking of?
So patients should always be up to date with all their vaccinations. There are other encapsulated bacteria, but there are no classical vaccinations available. So I tell my patients that these vaccines are to prevent this one type of severe infection, but that doesn't mean that they shouldn't be cautious about other things.
The acetylcholine receptor antibody has already been formed.
Yes.
What we're trying to do is make sure that it doesn't do its dirty job.
Yes.
That's really what all we're doing. But we haven't really turned off the formation of the antibody. We haven't hit the T cells, hit the B cells, gone sort of upstream. What do you think of that, and how do you think that influences the paradigm of treatment?
I do think that complement inhibitor therapies definitely play a big role. From the data we know that irrespective of what other therapies they're on, it makes a difference for patients' quality of life, their symptom burden. In practice, I try to combine complement therapies with other therapies which work upstream, which work on B cell or T cell and reduce the antibody burden. Eventually, I suspect to get to a state where patients are completely asymptomatic for a long period of time on a consistent basis, we have to come up with an optimal strategy which addresses multiple pathways in the disease causation.
That was great. Thanks, Sri, for joining us today. Appreciate it.
Thank you for having me.
Always
Absolutely.
good to talk to you.
Wonderful to talk to you, Pushpa.